This is Dr. Craig, and welcome to Top 10 Radiology. Now let's review prostate cancer. So prostate cancer, like breast cancer, is staged using the TNM system, which again is found in the AJCC Cancer Staging Manual. Well, this cancer staging is typically done by MRI, at least the local diseases. The extra capsular findings can sometimes be seen on CT. Regarding the T staging, you can think about prostate malignancy being in the prostate, extending into the seminal vesicles, or extending into the adjacent organs, such as the bladder or rectum. Regarding lymph nodes, 8 millimeters is the usual cutoff per PIRADS, although smaller nodes can harbor malignancy. You'll want to report on the regional nodes typically seen on the MRI, which are pelvic, hypogastric, obturator, internal, and external nodes. It's important to note that common iliac nodes are non-regional and therefore considered metastatic disease. Regarding the top 3 metastatic locations, bone is most common. Again, noting the Hounsfield unit number is important for distinguishing non-treated malignancy from bone islands. Non-regional nodes come next, followed by liver and lung, but notice how common bone mets are relative to the other categories at 84%. Some pearls of prostate malignancy or complications of prostate malignancy include skeletal related events. So think about issues related to pathologic fractures, including hip fractures, jaw osteonecrosis, which can be a side effect of the medication they take, zoledronic acid, and then spinal compression fractures, just like breast, where you have to note if retropulsion is present because that can compress the spinal cord. Some pearls for prostate cancer include that if those without bone mets had a high likelihood of nodal disease and disease to the liver and thorax. So if you don't see any bone mets, you want to look for abnormal lymph nodes because that's just the alternate pathway it's taking. Those with bone mets had a higher likelihood of liver and thoracic than the nodal spread that you typically see. And then when the skeleton is the primary metastatic site, up to 20% of patients will harbor metastasis and additional atypical sites, so you still have to keep your eyes peeled. And then I had a really hard time initially looking for lymph nodes or evaluating lymph nodes on MRI, but it's just really important to know that typically nodes will follow the major vessels. And so if you are unsure, just keep your eyes on the internal and external iliac vessels, and you'll likely see abnormal lymph nodes if you follow it there.
Okay, let's review a prostate cancer study. So I think this person has been treated in the past, so I'm just going to kind of quickly review. This person's prostate looks pretty small. I don't see any mass-like enhancement here. I know that this patient's been treated in the past, so this is just kind of a follow-up study. So when looking here, I try to find anything related to the prostate that looks abnormal. Again, my hint of following the pelvic vasculature is really helpful in this. And again, looking for common iliac disease, which is, again, a non-regional node in this case, following the external iliac, and I don't see anything here along the medial margin. We'll do it the same side over here as we go along. I don't see any abnormal lymph nodes that measure greater than 8. This is just a small little guy that could harbor malignancy again, even though it's a small tumor. Then I want to look for obturator nodes, which is one right here. I'm just kind of looking for the pelvic sidewall. So again, these ones are small. And then internal iliac and presacral. Nothing is coming out as abnormal here. Okay, so we have a patient that doesn't have any nodal disease. Now, again, if I was to think about this as a staging scan, I would want to look at the bones because the bones are going to be the most important, most common at a high likelihood of malignancy or metastatic disease. As I'm coming down here, I don't necessarily see anything abnormal. This just looks like a vascular channel, and some SI joint air. Okay. But one thing was noted was this little guy right here. And so that was actually new from the prior. You'll have to trust me on that. And it measures 810. So despite the fact that this person has been treated, I'm not exactly sure if they've been treated with a bone specific um, therapy like Exjava, but this is new from prior, and we could confirm it with a nuke med bone scan, which is what we do commonly here. And then here is another sclerotic lesion, but if we do an ROI on this, we see that the Hounsfield unit's over 10,000 or 1,000. So again, if this patient wasn't being treated, this would be more likely a bone island in this case, and that's kind of a common spot for them. Okay, so now that we have bone and we don't see any abnormal nodes as we go up here, so bone only without regional lymph nodes has a higher likelihood of hitting the lungs and the lungs and the liver. And so as I do a quick run through the lungs, you'll see that there's a node there, a node there, and that one actually spiculated. So that's highly concerning, probably a fissure lymph node. So assuming that these are new and assuming that I absolutely presume that one is malignant. And this other one here, this would be highly concerning for a thoracic disease. And now going into the liver, as I do my bone windows here, or liver windows rather, see kind of heterogeneous. That is a lot darker than this. So I think that is just simply hepatic steatosis. Looking through the right, portal vein 4 and 2, we see this guy. And so this one might be too small to characterize, but given 25 is a little bit higher than expected if I'm putting an ROI, and I'm assuming that there's no volume averaging here because I'm in the center of the lesion, then I would actually be highly suspicious for this, and I would want to double check on the prior to see if it was there or not. But given the fact that they don't have nodal disease, but they do have thoracic disease and possible liver disease, that kind of makes sense with the pattern that we talked about, saying that those with bone mets have a higher likelihood of liver, then thorax, then nodal, then brain disease. Okay, let's review our second prostate case. This is, I just want to kind of reiterate the bone findings on this case. This patient has been treated in the past. They've had a prostatectomy, as you can't really see it there. The bladder's still there, which is one form of therapy. And so again, if we're going to talk about lymph nodes and evaluation, I want to follow the external out. That's where it's going to be most common. We see a 7 millimeter, so it's kind of borderline enlarged. I'd want to compare with priors to see what that looks like. There's a group here that are also very small lymph nodes that don't meet the 8 millimeter criteria, but again, that doesn't tell us that there's no malignancy there. And so this person has pretty extensive bony disease, and I want to show you this. I typically evaluate this on sagittal views here because it's really easy to see the spine, which again, that's where the most common bone met is going to be. And it gives you a view of the sternum, which is a very overlooked bone, especially in trauma cases, actually. So in this case, I'm going to show you this guy here. So this person has been treated with Exjava, so to help reduce SREs or skeletal related events. And if you look here, the Hounsfield unit is 955. And so that's over that 885 threshold. But again, that threshold does not hold true when it comes to treated malignancies, as these lesions are going to get bigger in size and increase in attenuation after therapy. So if we look here, say this is the pre-treated case, you could see that the Hounsfield unit is 629, and so that kind of more fits into it. And so just because this lesion has grown in size and increased in attenuation, that actually doesn't say much about if this is progression or not. In this case, if I wanted to call progression, I would start looking for the smaller bone lesions in the sternum or in just random places that you didn't catch them before. again, looking for the small one helps you because those are the ones that are going to be new since they haven't been there as long. They haven't had a chance to grow as much. And so in this case, it looked like, yep, see right here. Looking at the sternum, again, looking in just random places can help you sometimes. There's a new bony lesion here. And so this would, in theory, be progression of disease.